Hello, hello. Can everyone hear me? Can everyone hear me?
We've got a few people in the chat saying yes.
Okay, thank you, Katie and Kay. We're just going to wait a couple of minutes. Usually people drip in the first 5 minutes, and then we'll start. How's everyone feeling this evening on this beautiful spring day?
Oh dear. The weather is miserable.
It's so bad. It's just awful. It was beautiful yesterday though. I went for a really nice walk and everything.
Yeah.
A little stroll in Regent's Park.
Nice. Okay. I can keep letting them in as we go.
Yeah, shall we start?
Yeah.
Cool. I'm just going to share my screen. Okay, so I don't know if my side's muted or if people actually can't see that.
It just says loading for me. If other people can post in the chat whether or not they can see it, it might be worth downloading it and then playing it as PowerPoint. Yeah, it says, oh, okay, I can see the first slide. Can anybody else see the first slide? They can see it.
But I don't know if that's me or not, if that's my laptop.
Yeah, no, I think people can see it.
Perfect. Okay. So, hi guys, my name is Arpan. I'm an F2, well, I was an F2. I finished in August. I'm currently doing a master's in sports injury and exercise medicine. So I feel like I'm fairly well placed to be able to teach you the basics of the joint exam. So welcome to this evening, Medicine the Essentials, OSCE Masterclass on the joint exam. So today we're going to go through the general rules of how to get through any joint OSCE with some additional stuff to help you get from a good pass to a really solid score in that test. We're going to go through the individual specific bits for each exam, special tests that you need to know, and give you some avenues where you can find some additional learning and information if you need it, and have a quiz at the end. We are recording this, so this will be up on YouTube if you want to watch it back later at your own discretion and pace. So just a couple ground rules before we start. So as much as possible, I want to make this as interactive as possible and get you talking back to me. It's going to be no fun for anyone involved if it's just me talking for an hour and a half. You guys are going to zone out. I'm going to zone out. My throat's going to get dry. That's just not going to be fun. So as much as possible, I've tried to avoid making the page really wordy and added loads of pictures. If you have a question at any point or want me to go back over anything, please just interrupt me and I can go through it, anything you need clarifying. Or if you're feeling a bit shy, you can stick it in the chat box and Natalie will keep an eye on that and let me know if there's any questions. And then finally, so I know it's really, really annoying, but please, 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 can you fill out the feedback form? The link will be in the chat box and will be sent to you at the end. We're a fairly new teaching organization. We're fairly fresh to this. This is all new for all of us. So your feedback will help us make these sessions as good as possible for the next sessions and for the ones going forward. So all we're asking for you to do is give some feedback. We've been made aware recently that some people have been charging tickets for these events. If you have had to buy a ticket, please can you get in touch with us and let us know who's been selling these tickets, because we need to stamp down on that. We are doing these talks from the goodness of our hearts. So I hope you get a lot out of it. This is the timetable of talks we have coming up. So next week we've got neuro 1, we've got a second neurology one the week after, and then it's pretty much every detail are the shoulder exam, the knee exam, and the hip exam. I think these are the most likely to come up. Oh, one sec. Oh, are we still frozen, Natalie? No, it's working.
You just froze for me for a moment. It might have just been me.
Okay, we're back. Sorry about that, guys. So the ones I'm going to go into in detail are the shoulder exam, the knee exam, and the hip exam. These are the most likely to be tested year on year. I'm going to skate through the hand exam because I think it's a fairly easy one to just rote learn, and there's not too much difficulty to it, but I will be going through it in some vague questions before we start.
Okay, it looks like it's not just freezing for me. I think it's freezing for everyone. It might be worth downloading the PowerPoint and presenting it from there rather than from Google Slides. I don't know if that's the issue.
Oh, okay. Which point did it freeze at?
It keeps freezing like every minute or so.
Oh, okay. How do I download it as a PowerPoint?
Next to the present, there's a little arrow on the top right.
Say that again.
Next to the present, there's a little arrow. Yeah, click that. Oh no, sorry. There's file. It's under file. File download is PowerPoint.
File, download, PowerPoint.
Yeah, and then just close it.
I don't know if that's worked for me.
It will do. Give it time. Sorry, guys. Give us a minute.
Oh, it is downloading. God, it's a big file. I didn't even realize.
It's all the hard work you put in.
Shut up. Ooh, okay. One sec. Sorry, I'm on a Chromebook, so Microsoft always goes a bit haywire.
If not, you can download it as a PDF and share it that way.
Yeah, maybe I'll try that. Sorry about this, guys. File, download, PDF. Oh my God, it's taking its time, isn't it?
All right. We've still got people joining late.
Oh, perfect. Right. Okay, let's try this again. How do I full screen this? Is this?
It might be worth going into your downloads and opening it that way, so it's not on Chrome.
No, it's going to come up as Chrome
Okay,
anyway.
that's fine.
Right, sorry about this, guys. Can I close this bar or not? There we go. Right.
Someone's asked if you can restart from the beginning. We'll go through the introduction very quickly.
Yeah, that's absolutely fine. Sorry about the breakdown, guys. Right, so welcome to Medical The Essentials, OSCE Masterclass Session 4. This is the joint exam. My name's Arpan. I finished F2 last August. I'm now doing a master's in sports injury and exercise medicine. So hopefully I'm fairly well placed to be able to teach you guys the basics of how to do a good joint exam for your exams. So just an overview of what we're going to do today. So we are going to look over the basics of doing any joint exam in an OSCE. We're going to go through the specific details which are going to take you from a good candidate to a very good candidate and above. We're going to go through specific information that you need to know for each exam and give you some links and that for other places you can get some additional learning resources, and we'll have a little quiz at the end. We are recording this and it'll be up on YouTube later today, so if you want to watch this back, then you are free to do that at your leisure. So just a couple ground rules. First of all, I want this to be as interactive as possible. It'll be really boring for everyone involved if it's just me talking for an hour and a half. And you guys are going to zone out, I'm going to zone out, no one's going to learn anything. So as much as possible, if you have a question, if you have a query, if you want me to go over something again, please shout out and let me know, and we can clarify anything that you haven't understood. Or if you're feeling a bit shy, you can put your question in the text box, chat box, sorry, and Natalie will be keeping an eye on that and will let me know if there's any questions. Also, last thing, please fill out the feedback form. We are a fairly new teaching organization. We're all new to this. It would be great to get some feedback. It'll help us make these sessions better and better every time. Additionally, feedback will be great for me. So I'm fairly new to this teaching thing. Once you get to my stage of medical training, you'll realize how valuable it is to have teaching experience on your CV. So please fill out the feedback. It'd be great for me and great for us. Also, we've been made aware that some people have been selling tickets for these events. All of our talks are completely free. If you have paid for your event, please let one of us know so we can track down who's been doing this, because we are doing these completely free from the kindness of our hearts, because we remember how terrifying it was to do these OSCEs, and we just want you to do as well as possible. So yeah, let's get started. This is the timetable of events coming up. We've got some really good talks coming up in the next couple of weeks. They're usually once a week, and should be able to cover everything you need for finals. Right. This is how we're going to go through this today. So it's now 6:15. Bit of a later start than I anticipated, but hey ho. I'm going to spend about 15 minutes going through the overview of how to do any joint exam. It'll give you just a good framework to go back to if you get stuck, and make sure your examination is really nice and systematic and smooth. The ones we're going to go through in detail are the shoulder exam, the knee exam, the hip exam, and the hand exams. These are the most likely to come up in your finals exam because they're really good ones to demonstrate science for. Shoulders, knees, and hips, I'm going to go into more detail. Hands, I will skate over because I think it's quite an easy one to learn, and it's more about observation. Additionally, I don't know if you guys will want this, but I've prepared slides for the GALS exam. I know outside of London, the GALS exam isn't really taught or used, but the London universities, especially UCL and Imperial, tend to like it. But if you guys don't feel that'll be useful, or you don't think it's on your curriculum, I'm happy to skip that, but it's up to you guys. Right, so general overview. How would you start every OSCE? Your first port of call are wipe a QQ, so that is your introduction to the station. So you're going to wash your hands, introduce yourself to the patient, ask for permission, expose the patient as necessary, and reposition them as you would like them for the exam. And then your 2 questions are you comfortable, and do you have any pain or difficulty with your movements? Then for any other organ exam, your go-to would be IPA. So you guys might be aware of that as an acronym. So inspect around the patient and then the patient themselves. You're going to percuss, palpate, and auscultate. However, joints do not really percuss. Joints do not really auscultate. You can palpate them, but if you start tapping around your patient's shoulder, I'm pretty sure you're going to fail that exam, especially if you start trying to listen to it. So what do we do instead? So the framework for a good joint exam in any joint is looking around the joint. You're going to feel around that joint space, move that joint through all of its active directions, and also move it passively. Functional tests, which are going to be specific to how that person uses that joint on a daily basis, and then special tests, which are going to test for specific pathology. At the start of your joint exam, if it is not made clear on the OSCE description before you start the station, you should always ask if the examiner wants you to do both sides. In a lot of cases, they'll say no, but sometimes they want you to do both sides. And then to complete your OSCE, you've got 4 things you need to tick off. So you present your positive findings. I wouldn't bother presenting your negative ones. So I wouldn't go through your entire exam saying this was negative, this was negative. Just present your positive findings, because that's what is going to inform your differentials. As far as differentials, you always present your most likely differential first, based on what you found in the examination. I would have at least 2 others that are possibles, and then if you feel like you need to raise any red flags that you would like to exclude as differentials, then you present that as your last one. You would then say, I would like to investigate in the following ways. So remember, when you're asking for investigations, you're going from the easiest things to get, which are things you can test at the bedside, to the things that are going to require someone else to do them for you, or someone higher up the chain. The things that differentiate people who just about pass to people who really excel in these exams are for you to have a stepwise logical framework, for it to be smooth, for your differentials to nicely match what you've presented as your findings, and for you to be able to speak on those differentials about what may be the causes and what are the further complications of that pathology. Right, let's start with the general overview. So when you are looking at a joint, some of you might have been taught the acronym DWARFs. So deformity, you're looking for any difference in the normal shape of that joint. Remember to compare the joint to the healthy side. So your healthy side is going to be a really good reference point. It'll be able to show you what that person's normal anatomical structure is, and it'll also tell you if there's any break from that. Wasting, so you're looking all around the muscles that act on that particular joint space. Asymmetry, so once again, you're looking for any malalignment, any change in the posture, anything that just doesn't look right compared to the normal side. Rashes, so rashes tends to be more for rheumatological conditions especially. I've added in redness as well. Redness is an important sign to look for, especially if you're suspicious of a septic joint. Fasciculations, which tends to be more specific to neuromuscular conditions, and scars, which is going to tell you if this patient has experienced any trauma around that joint or any previous surgeries. Feel, so you want to feel along all the joint lines around that joint space. Make sure before you start feeling around the joint, you are preparing the patient and saying, look, this may be a little bit painful. If it becomes too painful at any time, please stop me and we can move on to the next part of the exam. And you're assessing for the point of tenderness. So sometimes it may be diffuse over an area. Sometimes it might be specific to one spot. Right, so movements. When you're testing the movements within a joint space, there's kind of 2 ways to do it, because you need to do the active and the passive. you can either get the patient to do the active range of motion first and then passively do the full range of motion after they finish, or you can get them to do the active range of movement first until they get stuck or it gets too difficult, and then you can passively complete the movement, which is called overpressure. Now, if you decide to do the overpressure version, make sure before you start pressing against that joint, you need to ask the patient, what is stopping you from completing the range of movement? Is it stiffness or is it pain? If it's stiffness, you can be fairly firm with your movement because it's likely some inflammation or cartilaginous change in that joint, which is preventing them from completing it. So you can be fairly firm, but without worrying too much. If it's pain, you need to be delicate with it. Otherwise, you're just going to cause this person a lot more pain than you need to. So you're going to go very smoothly, very slowly, and complete that movement to as much as the patient is able. So up to the point where the patient stops you, or where you feel resistance beyond what is comfortable. As well, when you're asking the patient to do the active movements, it's probably easier in most cases to just demonstrate the movement rather than say, can you abduct your arm? Can you flex your hip? Because the patient's not going to understand what you're talking about. And then functional tests. So when you're assessing for function, you want to think, how is this person using this joint in space? So if it's lower limb, you're thinking about weight bearing, you're thinking about walking. Are they having difficulty with stairs? Are they, whether up or down? What movements are they going to use in their daily lives? If it's hands, you're thinking about, are they having difficulty with fine movements? So things like using a pen, doing up buttons, dressing themselves. With the shoulder, you're thinking about, how are they getting their arm into a sleeve? That kind of thing. So really think about how that joint is used by your regular person on a day-to-day basis. Additionally, in a lot of exams, sometimes they place a prop very obviously. So maybe it's a pen, maybe it's a button, maybe it's a coin. So make sure if there's a clear prompt, use it because they've put it there for a reason. Or sometimes you've just stolen the examiner's pen, but hey, maybe it'll help, maybe it won't. Right, gait I've put as a functional test, especially for any lower limb exam. So all you need to do is get them to walk a couple meters, turn on their heel and come back to you. And you're assessing for the 5 S's. So smoothness, you want a smooth trajectory of the hip through the stride of the movement. Swing, you're looking for an even arm swing, both sides. Symmetry, you're looking for the spine to be nice and central and upright, and for the stride on both sides to be the same. Stride, you're looking for a nice, strong, long stride. And then speed of turn, you're looking for them to quickly be able to turn around and come back to you. Speed of turn is especially relevant for patients with Parkinson's, who tend to have that very shuffly gait. They'll have a wider turn circle and have a much slower speed of turn. These are the 4 gaits that I think as a finalist you should be able to describe. So antalgic is your painful limping gait. Ataxic is your wide-placed clumsy gait. Hemiplegic, you're going to be leaning to one side with some weakness. And Parkinsonian, as I said earlier, is going to be more of a shuffly, slow gait. I was going to put videos on here, but it was just too difficult to put them on. But make sure you just watch a couple on YouTube just so you have a very good idea in your head of what they look like. And then these are the special tests. So these are all the ones you should be expected to at least describe in a finals exam. I would say the ones I put in bold, so especially the ones for the shoulder, the hand, the hip, and the knee, you should be able to demonstrate on a patient and know what a positive sign is. So those are the ones you absolutely just need to be able to rote learn. The other ones are slightly less important, but you should be able to demonstrate them in the exam. And then when you finish examining, you turn to your examiner and say, to complete my exam, I would examine the joint above and the joint below. So say you're doing the knee, you would examine the hip and the ankle and do a neurovascular exam of the limb. And that is it. That is the basics of doing a joint exam. Does anyone have any questions before we proceed, or anything you want me to go back over? I'm going to assume, because it's silent, that you guys want me to continue. So let's get into it. Right, we will start with the shoulder. The shoulder exam can be a little bit tricky because, like the hip, it kind of...
Sorry, someone's asked to show the slide again. I'm assuming the one with all the special text on it.
Oh, yeah, sorry about that. Yeah, feel free to take a picture or screenshot. All good? Okay, I'm going to move on. Right, so shoulder. First port of call is to look. So remember, you're looking from the front, you're looking from the side, and you're looking from the back. I put a couple classic pathologies up here for you. So can anyone describe what they see in the first picture on the left?
Horns.
Say that again for me. Oh, I don't know if that's me freezing or...
Axillary nerve damage.
Okay, what makes you say axillary nerve damage?
Wasting of deltoid muscle.
Okay. What else can you see in the patient's shoulder compared to their normal side? Oh, actually, first of all, tell me which one is the affected side.
Right side.
So the patient's right, yeah, exactly. And can you just describe what you see?
So like in that nice smooth curve of like you can see in left side that is disrupted in the right side.
Yeah, perfect. So you've lost that nice smooth arc of the deltoid there. You've got a very prominent acromioclavicular joint. As well as that, so you can't see because the bottom of the picture's cut off, but the patient's actually cradling that arm and lifting it up slightly. Can anyone give me some possible diagnoses for this patient?
Lots going on in the chat.
Oh, I can't actually see the chat.
So, God, 8, 9, maybe 10 people have said dislocation.
Perfect, yeah. So it is an anterior dislocation of the shoulder. So this is very classic. The cradling of the arm is a very classic sign. In very thin people, you may even see the head of the humerus sat in the just in the groove next to the top of the pec. In anterior dislocations tend to be a lot more prevalent than posterior. I think anterior make up maybe 90% of dislocations of the shoulder compared to posterior. Right. Can anyone tell me what they see in the second picture?
Winging of scapula.
Perfect. Can anyone tell me some causes of winging of the scapula?
Long thoracic nerve damage.
Perfect. Yeah, that is the classic one. As well as that, you've got scapular dysfunction, but for a finalist, you don't need to know anything about scapular dysfunction. That's more of a sportsman specific pathology. But yeah, long thoracic nerve is your go-to. And then can anyone tell me about the third picture?
Clavicular dislocation or fracture.
Can you say that again?
Clavicular dislocation or fracture.
Okay, yeah. So what's happened here, you've got a rupture of the acromioclavicular joint. So as you can see, that the distal end of the clavicle is completely displaced from the humerus. What's happened is they've likely had a downward force applied to the top of the humerus, which has completely ruptured that ligament. And so you have this kind of clavicle hanging out in space. Very common injury in rugby. I shouldn't say very common. It's more commonly seen in rugby or similar contact sport. So feel. So I always start from the front and work my way around. So I would start at the sternoclavicular joint, feel my way up the clavicle, go to the acromioclavicular joint, feel round to the head of the humerus, feel down for the for the shaft of the humerus. And then from the acromioclavicular joint, I work back around the top of the scapula and then go down the spine of the scapula. And that's all you really need to feel for the exam. And then move. So remember, the shoulder moves in kind of a 3D space compared to a lot of the joints. So you've got your flexion and extension, abduction and adduction. Remember when you're presenting that to really pronounce the B and the D and make sure the examiner knows that you know what you're talking about. And then you've got internal and external rotation. And then functional tests. So the two functional tests they classically ask for at finals level is hands behind the head. So you get the patient to abduct both arms and then put their hands behind their head. They're then demonstrating external rotation of the shoulder and abduction of the shoulder. And then the other one is you get them to reach as far up their back as they can with each arm. Sometimes they get them to swing their other arm over so their fingers touch in the middle, but you don't always have to do that. That is demonstrating internal rotation of the shoulder and a little bit of abduction, but not as much. Adduction with a D, but not as much. Right, we're getting into the rotator cuff test now. So your classic supraspinatus test would be a resisted initiation of abduction. So you get the patient to start completely relaxed, put your hand on their elbow and get them to initiate abduction of the arm. And it's the first 15 degrees that the supraspinatus is involved with. After that, the deltoid takes over and completes the rest of the movement. In all honesty, this is not a great test. It's moderately sensitive, but it's not specific at all. So it's not the best test for supraspinatus, but it is the one they will ask you for medical school finals, unfortunately. Okay, and then you've got external rotation. So you get the patient to tuck their elbow in against their ribs and rotate their hand out while you resist the movement. And that is testing infraspinatus and teres minor. And then you've got basically the reverse with them rotating their arm inwards, which tests subscapularis. And then you've got the anti-can test. So you get them to flex their shoulder completely forward and pronate the forearm, so their thumbs are pointing down. And then you can apply some gentle pressure on top of that, which is a really good test for eliciting the supraspinatus, far better than the initiation of abduction test. And that is the shoulder pretty much done. Does anyone have any questions?
Someone's asked to repeat which ligament was damaged in the last photo that you had of pathology on inspection.
Oh, the third one here?
Yeah.
So that would be the acromioclavicular ligament. It's not a pathology I would expect you to get in finals because it's traumatic and the patient would have probably had a surgery on the day, but...
Okay, they say thanks. They say, would you also throw in scarf? Sorry, what do you mean by scarf?
Oh, so the scarf test, I didn't put in the scarf test on this because it just wasn't on the mark scheme that I found online or in the book that I had. The scarf test is you get the patient to place their hand onto their opposing shoulder. So they're almost wrapping their arm around the front of their chest, and that will test abduction and some, I think, subscap. But it's not a test that I've used in a long time. Sorry about that. Everyone happy? I'm going to assume that's a yes. Okay, so the knee can be tricky because there's so many ligaments that stabilize the knee, but it does not have to be as scary as it's made out to be. So as with before, you are going to look from the front, you're going to look from the side, you're going to look from the back. So in the little cartoon on the left, you've got two different stances. Can someone tell me what they see in the first stance on the left?
A couple of people have put varus in the...
Okay, so yeah, It is actually varus. So when you're deciding if a joint line is varus or valgus, you're looking at the distal portion of the joint. So the distal portion in this case is the tibia fibula. And if it's going towards the midline, then it's varus. If it's going away from the midline, then it's valgus. Can anyone tell me what's happening in picture 2?
Someone's written effusion, someone's written patella. The middle image.
Yeah, the middle one.
Another person's written effusion.
Yeah, so there's pretty significant effusion in this case. It could be potentially a bursitis. I wouldn't expect the swelling to go so far up the thigh. In a bursitis, it tends to be more focused. I would also in bursitis expect a little bit more redness. And then in the third picture on the right,
Someone's already put Baker's before you even asked.
great, brilliant. Yeah, that is in fact a Baker cyst. Remember if you are presenting Baker cyst as a differential, Baker cyst is always caused by something else. It's always a presentation of something else, whether it's effusion. Let me remind myself what the pathology of Baker cyst is. We'll come back to that, one sec. Yeah, so a damage to any of the ligaments of the knee can cause a Baker cyst. A tear in the meniscus can cause a Baker cyst, or if you have impingement of the joint space, such as in osteoarthritis, where you lose that joint space, any of these can cause a Baker cyst in the back. They're not always pathological and they're not always troubling to the patient, but if they become painful, then you need to think about treating or draining them. Right, feel. So when you're feeling through the knee, I would start above the patella, feel the insertion there, feel around the patella itself at number 2. Definitely make sure you feel the joint line. The joint line is so important because joint line tenderness is a classic sign for meniscal tears. I would then feel at point 4, which is the patella tendon, 5, which is the tibial tuberosity, and then I would go around the back and feel for any potential aneurysms or Baker cysts. When you are feeling the knee, do not forget to comment on the temperature of the knee, as it's probably the most common site of septic arthritis in adults. And then effusions. So there's 2 different ways to do a test of an effusion. You can either do your patella tap test or you can do a sweep test. My personal preference is the patella tap. I think it's a lot easier to execute, especially in an exam scenario. And the positive sign is a lot easier to feel than it is with the sweep test. So for the patella tap, which is pictures A and B, you're going to have one hand firmly placed above the patella, one hand placed kind of just below the muscle bulk of the calf, and you're going to squeeze your way up with the distal hand until you get to the patella. When you get to the patella, you're going to use your index finger to just tap the patella. And if there's an effusion, it almost feels like it is floating in space when it taps. It's not like in a normal knee, you won't get a patella tap. It won't feel like it's floating above some fluid. It'll just be firm. In someone with a patella tap, it's going to almost float in space. So that I find that much easier sign to elicit than the sweep test. The sweep test, to me, I find just a little bit too sexy for day-to-day use, and it's just kind of weirdly intrusive for the patient. Also, it's really hard to see a positive finding with a sweep test, but I'm going to tell you how to do it anyway, just so you're aware. So your proximal hand is going to be kind of in the same space as where it was for the patella tap. What you're going to do, you're going to sweep the fluid up the medial aspect of the knee using the back of your hand towards the patient. And you're going to keep sweeping for like 3 or 4 times. What you're then going to do is gently slide your proximal hand down. And what you're looking for is for the empty space that you've kind of drained upwards with your hand, medial of the patella, to refill with fluid. Now, for me, that's just a lot of steps and kind of a weirdly intrusive test to inflict on a patient for a very minimal reward. Even in a patient with an effusion, it can be hard to kind of see that joint space refill. It is completely your choice which effusion test you use. My personal preference is just the patella tap. I think it's quicker and easier to do. And then movement. Movement tends to be really easy in the knee. It's a hinge joint, so you're only going to go through flexion and extension. Make sure when you're doing passive movement of the knee, you comment on crepitus. So crepitus is any crunchy, grainy feeling of the knee when you move it through those through that range of motion. Right, now we get onto the ligaments. So I would start with the MCL and the LCL because they're easy ones to knock out early. So you get your patient to lie back and straighten their legs out. Some people find it easier to sit between the patient's legs. I find it easier to do that. Otherwise, you can stand at the bedside, but it's just a bit easier to get a bit more purchase if you sit at the bottom of the bed. You place one hand just above the joint, just above the patella, one hand firmly holding the lower part of the shin on the opposite side. So your hands are on opposite sides of the joint, and you apply just a very gentle pressure to try and cave that knee side to side. And it's a really good test that I still use today. Right, then you get your patient to bend both their knees to about 45 to 60 degrees. If you have a patient with a posterior sag, so remember the posterior collateral ligament attaches from the front of the femur to the back of the tibia. So if you lose that, there's nothing stopping the tibia from translating backwards. So you can either test posterior sag with the patient's knee at 60 degrees and just watch the tibia kind of fold backwards, or what you can also do is get the patient to straighten both legs and relax, hold both feet and gently lift. On the affected side, you'll see the knee cave back on itself, and that can be a really useful test because you're testing both sides at the same time and can compare to the normal. It's very rare that you'll have a both-sided collateral ligament tear. You have to go through a pretty major trauma to have damaged both. Then we get to anterior and posterior draw test. So this is where the position of your hand should be. Your fingers should be either side of the patella tendon with your thumbs should be either side of the patella tendon with your fingers wrapped around the muscle bulk of the calf. And then you can pull for the anterior cruciate ligament and push for the posterior cruciate ligament. So when I'm doing a draw test, I'm going to take you back to the previous slide. I will always do a posterior draw first. Reason being, if your patient has a posterior collateral ligament tear or rupture, this will be their resting position of their knee. So the tibia will be in relaxed position, anteriorly displaced, and that'll be their resting position. If you do an anterior draw test on this patient and pull forward, it's going to feel like a positive test because you'll have translated that tibia forward. In reality, all you're actually doing is translating that tibia to the neutral position of where their knee should be, where the tibia should be. So you'll get a false positive. Whereas if they have an ACL and they bend their knee, there's a lot of other things that will stop the tibia from translating anteriorly rather than posteriorly. So it'll look normal when you just bend the knee, and there's nothing stopping you from doing the posterior draw then. Does that make sense before I move on? Natalie?
Yeah, someone said yes. A few people, one person said repeat. Okay,
so let's say you have a PCL tear. In that case, you've bent the knee to 60 degrees. Not 60 degrees, 90 degrees. Sorry, I'm not good at maths. and this will be the result. So there's nothing stopping the tibia from being translated posteriorly because you've lost that PCL. It's just been popped. So this will be their resting position of their tibia compared to their femur in the knee. If you start doing an anterior draw test, so you've got your thumbs on either side of the patella, you've got your fingers around the back of the muscle bulk, and you pull, what that's going to do is bring the tibia forward. Now, if the ACL is not damaged and is intact, the ACL is going to stop you from bringing the tibia beyond the neutral point. But for you examining, what it'll feel like is like you've pulled the tibia forward, which would be a positive finding in an anterior draw test. So if you have a patient with a PCL or any knee trauma, for that reason, I will always do the posterior first, because if the posterior is positive, then I'll know that it's very unlikely that my anterior draw will also be positive unless I'm able to bring the tibia beyond what I would consider the neutral position of the knee in a normal bent knee. And it's very, very rare that you damage both because they are damaged in such opposite positions of the knee when you do it as a kind of twisting injury. Does that make more sense? Anything in the chat?
People have written yes. Someone's written, so if the PCL is damaged, it affects your anterior draw test. So you should do the posterior draw test first.
Yeah, perfect. Thank you, guys. Right. So that's your anterior posterior draw. Lachman's. Okay. So Lachman's is a little bit of fiddly one. I find it fiddly myself, but we'll get through it together. Give me 2 seconds. Okay, so you have your knee bent at about 30 degrees, not even that bent. You externally rotate the tibia to about 20, 30 degrees, not even that much. You have one hand behind the hamstring, one hand behind the calf, and with your thumb over the tibial tuberosity, with your distal hand over the tibial tuberosity. At that angle, you pull. So it's very similar to an anterior draw, just with a twist. The Lachman's test is slightly more specific for an ACL tear. So I'll go through that again. You have your patient's knee bent at about 30 degrees. You then externally rotate the tibia by about 20, 30 degrees as well. You got one hand under the hamstring, just stabilizing the joint. One hand under the muscle bulk of the calf with your thumb over the tibial tuberosity, and you give it a firm tug. What it should feel like is it pulls forward and it'll have almost like a very soft, spongy feel, whereas in someone with a normal ACL, it won't tug forward and you'll just have a firm resistance. It does tend to just be a little more sensitive than an anterior draw because it excludes a couple of other structures that stabilize the knee. Okay, that is your Lachman's test. And then McMurray's, right. McMurray's is the one that you always get told every year you should know how to do it, but in the exam will stop you before you do it. However, I know someone who went into an exam thinking, I don't need to know how to do McMurray's, it'll be fine. They're going to stop me before I actually attempt it. And then when he said, I'm going to do a McMurray's now, the examiner let him do it. So it is important you should be able to demonstrate it. The reason they stop you is it's very uncomfortable for the patient, even if they don't have a positive test. But it is actually a very good test either way. So the way you do a McMurray's test, you've got your patient lying back, you get them to fully flex their hip as far as possible and fully flex their knee. You have one hand on top of the knee and you externally rotate for the lateral collateral ligament or internally rotate for the medial collateral ligament, the foot. You then slowly extend the hip and knee. So you straighten out that leg very slowly. If the positive finding from McMurray's is pain, and it's not just a little bit of pain, it's severely painful if you have, sorry, did I just, oh, I said sorry, I said ligaments when I meant meniscus. Blah. So you externally rotate the foot for a lateral meniscus. You internally rotate the foot for a medial meniscus. You then very slowly straighten the leg. And it's extremely painful in a positive test. So do it carefully. Even in someone with a normal knee, it'll be uncomfortable. So do it carefully. You should be stopped. 90% of the time you'll be stopped before doing it. But it may be the case that they ask you to talk through what you would do. So just be prepared. Does anyone want me to go through that again? Because I fumbled what I was saying.
Someone wants you to go through Lachman's test, and someone says, yes, please, if you could go through that again as well.
Okay, let me go back through Lachman's. So, Lachman's, your second test for an ACL, slightly better than an anterior draw because it excludes a lot of other structures that stabilize the knee. This picture is the start position you should have your patient in when you start the exam. So you've got one hand under the hamstrings to stabilize the joint. You've got your other hand under the muscle bulk of the calf with your thumb over the tibial tuberosity, which is more medial than this guy's thumb is, but so be it. You rotate the tibia about 30 degrees outwards, and then you give it a firm tug. In a normal person, the ACL will be completely intact, so it'll be a firm, solid feel, and it with no give. In someone with an ACL tear, you'll get a little bit of forward translation, and it'll feel almost spongy because your only resistance in that case is the medial collateral ligament and the muscles that insert into the tibial tuberosity. Okay, so bend the knee to 30 degrees of flexion, rotate it out 30 degrees, hand round the back of the muscle bulk of the calf, thumb over the tibial tuberosity, firm tug. Okay? And then McMurray's. Sorry about this, I completely fumbled what I was saying. Right, so McMurray's, you've got your patient on their back. You get them to bring their knee as close as possible to their chest. So that's a full flexion of the hip and a full flexion of the knee. You then place one hand on the top of the patella and use your other hand to externally rotate the heel to about 30 degrees outwards for the lateral meniscus and 30 degrees inwards for the medial meniscus. You then slowly extend the leg, straightening very slowly because it's extremely sensitive even if you have a normal meniscus. In a patient with a damaged meniscus, it is excruciatingly painful and a very good test for meniscal tear, if not completely fun for the patient. Is that a little bit clearer?
Someone said yes. And someone's gone, so is it just the heel you rotate?
So you're firmly holding the ankle, the foot and ankle, and rotating to rotate the tibia. So if you think where the menisci are, if you rotate the tibia, those are going to turn slightly. So when you extend, whatever bit of that is damaged is going to elicit a lot of pain. So yeah, it's more the ankle you're rotating, but you're holding from the foot because the foot is just going to give you more purchase than if you're holding from the ankle.
And then someone's written, when will the patient feel the pain? Is it when you're extending the foot?
Yeah, so it's a passive extension. So when you're straightening, so you straighten the knee and the hip out at the same time, so you're kind of folding it out very slowly. Where they start getting the pain tends to be, it tends to be just before they get to 90 degrees of flexion at the hip. but it can vary depending on where their meniscal tear is and how big of a tear it is. But I would expect them to start getting pain before their knees pointing straight to the ceiling.
And someone's just asked about Lachman's again. They said, are you tugging it sideways, and are you trying to pull the tibial head forwards?
You're tugging directly anteriorly. So even though the tibia is rotated out, you're still tugging anteriorly in the joint line, so straight ahead. Yeah. You're not trying to fully translate the tibia out, but you're giving it a firm tug to see if there's anything that's gonna hold the head of the tibia in place. So yeah, it's a firm tug anteriorly. You're not trying to fully displace the tibia, but the test is more for the end feel. So if it feels firm and like you've got resistance, then it's likely a normal ACL. If it feels soft and spongy, then you've lost the ACL. Because remember, the ACL is a very collagenous ligament, whereas all the other stuff that stabilizes the knee is softer, it's muscle. So it's going to have more of a spongy, elastic feel, whereas the ACL will feel firm and less. No, let me not use that word because that'll confuse you further. It'll just feel like firm, almost like slightly stretchy plastic, as opposed to rubber. Is that okay?
No more questions for now. I think we should probably move on from knee stuff. And if there's any questions at the end about it, we'll go back.
No worries. Okay, hips. Hip exam is a favorite of OSCE finals because there's so many patients with painful hips. In a hip exam, in any joint exam, the most likely patient you will get is an osteoarthritis patient. Reason being, they're everywhere. There's loads of them they can recruit. 2, the pain tends to be not that bad and the patients are very well. And 3, even if they can't get a patient with osteoarthritis, they're really easy signs to fake. So just remember that when you're examining the hip. When you're asked to do any joint exam. Sorry about that. Right, so as with any exam, so I usually start with gait for hip, just because they tend to be standing already, and gait will give you a very good amount of information right from the start. And remember, you're looking for the 5 S's: smoothness, stride, symmetry, speed of turn, and swing. Thank you. Right, trendelenburg. This tends to trip people up. So trendelenburg test, you get the patient to stand in front of you completely relaxed. Some people, so I do this as well, you can put your hands out, palm face up, and get them to rest their hands on top of yours before they start the test. I find this actually a really useful tool because it'll give you some additional information. You then get them to raise one of their feet off the floor and balance on the other. So in a normal person, you'll be able to adjust the tension in your hip stabilizers to be able to keep your pelvis level. If you have weak hip abductors for any reason, so weak glutes, you will tilt away from the affected side. So if you take this picture as your example, this person has weak glutes on the left because they're not able to pull the right side of their pelvis up level when their foot is taken off the floor. They're not able to compensate for the lack of stability in that case. Does that make sense before I move on from trendelenburg? Because I know it's a little bit fiddly. So you lean away from the affected side, you lean down.
People saying yes.
Cool, excellent. Additionally, if you're doing the version where you keep your hands out and get the patient to rest their hands on yours, you may feel some pressure on the hand away from the affected side as well. That's just them trying to compensate as well. So I do that version with both hands out. Feel tends to be really short for the hips, so you want to feel for the greater trochanter, feel all the way up to the ASIS, and then down towards the pubic symphysis. Most of the time, the examiner will stop you before you get to the pubic symphysis because it's a little bit invasive for the patient. While you are feeling, so I usually do the feel with the patient lying back. While you have them on their back, you can do your leg lengths. So you've got your apparent leg length, which will go from the ASIS to the medial malleolus, and your true leg length, which is your xiphisternum to your medial malleolus. Make sure you do both sides, otherwise it's kind of a pointless test. You need to know if either side is shortened. A shortened apparent or true leg length can be a very classic sign of fracture neck of femur, so make sure you just get it done. Usually as well, as we said earlier, if there's props out, use them. They will have a little tape measure out for you to do that. And then movements. So the hip, like the shoulder, can move basically almost in a hemisphere. So you've got flexion, extension, abduction and adduction, and external and internal rotation. So you test all of them passively, test all of them actively. Once again, you're feeling for pain, stiffness, and crepitus. And then Thomas test. Thomas test can be a little bit fiddly, but it's actually a really good test. So you get your patient to lie back on a couch with their knees hanging off the end of the bed. You then get them to bend one leg as far as they can to their chest, and get them to grab it and pull towards themselves by themselves. A positive Thomas test. So in this case, he's raised his right leg towards him, and his left leg is hanging off the end of the bed. A positive Thomas test is either if the resting leg, the leg that's against the bench, lifts off more than 10 degrees from the bed, or if they're unable to keep a flexed knee, so if that knee straightens out, or if they have to arch their back, their lumbar spine, in order to keep their resting leg on the table. Any of those will show that there's a tightness of the hip flexor muscles. So rectus fem, iliopsoas, tensor fasciae lata, any of those. Tightness of those is what is going to give you a positive Thomas test. Everyone happy with that?
Someone's asked, can you do this test without the leg hanging off, or is that an essential?
I was always taught with the leg hanging off the end of the bed. I think if you have them lying completely flat against the bed, you can't test then if the knee extends on the resting side. So I was always taught it with the leg hanging off the end of the bed. Okay. That is the hip exam. The hip exam is not hard, and it's quite easy to get a lot of information out of it. Make sure you do your gait because it's so important for the hip exam. It gives you so much information. I'm going to go to the hand exam. Does anyone have any questions on the hip before I move on?
No other questions at the moment.
Perfect. Right, so as I said earlier, I think the hand exam is fairly...
Oh, never mind, sorry, someone's written Thomas test result findings. So if it's positive, what does that mean?
Okay, so a positive Thomas test... Ooh, give me 2 seconds. So a positive Thomas test means you have tightness or restriction of the hip flexor muscles on that side. This can be due to a couple things. So it can be inflammatory, or it can be due to deconditioning or to some neurology. But the issue is what it does is you end up with a malpositioning of the pelvis, which gives you very poor posture, which can then lead to problems in the spine and problems in the knees, because they then compensate for how your pelvis is then sitting. Okay. Right. So the hand exam. I think it's a fairly easy one to just rote learn, so I'm not going to go through it in detail. Most of the marks in the hand exam that you'll find in OSCE will be for what you see. So they tend to get patients with really obvious visible signs rather than signs you elicit when you are getting them to move through the joint line. So we're going to go through just a load of pictures and talk about each one and what the diagnosis is. So, general examination of the hand. Can anyone tell me what's happening in the patient on the left? Or just describe what they see.
Lots of people written RA.
Hmm?
RA. I think
Perfect.
rheumatoid arthritis. Someone's
people
written
name-
ulnar deviation.
Perfect. Yeah, ulnar deviation, very classic sign of RA. Can anyone tell me what is happening in the second picture?
Someone's written scleroderma.
Perfect. So the positive sign here is that if you look at the skin of the hands, you have very shiny, tight looking skin. So she doesn't actually have so much of a problem in the joint, more that the skin is so tight that it's constricting how much she can move her fingers. Okay, let's go into palms. Can someone tell me what's happening to the left patient?
People have written Dupuytren's contracture.
Perfect. And can you tell me the classic OSCE finals cause of a Dupuytren's contracture?
Someone's written liver disease.
Yeah, liver disease, and especially alcoholic liver disease, Dupuytren's is a classic sign. In real life, Dupuytren's, most of the cases, I think over 50%, are idiopathic. So this is a synovitis around the tendons, so you get tightening. Remember, with the Dupuytren's, you don't always get the claw-shaped hands. Sometimes you just get a very pronounced tendon, like in this patient. Can someone tell me about the patient on the right?
Someone's written thenar wasting.
Perfect. And what are the two classic causes of a thenar wasting?
Someone's written nerve injury, median nerve damage,
Yeah.
median distal proximal carpal tunnel.
Yeah, so carpal tunnel and median nerve injury are the two classic causes of a thenar wasting. Okay, scars. So can anyone tell me what procedure the person on the left has had?
Someone's written surgery.
Great, excellent. Can you be more specific?
Someone's written carpal tunnel release. Trigger finger release, someone's written.
Yeah, perfect. So this is a trigger finger release. So it's going to be fairly close to the knuckle. So trigger finger is a tenosynovitis. You end up with a it tends to mostly present in the little finger, the ring finger, hence trigger finger, because it looks like you're holding a gun. Can anyone tell me about the patient on the right? Or what they've had, rather?
Carpal tunnel release.
Perfect. So remember, with a carpal tunnel scar, it's always going to be higher than you think it is. Additionally, in some of the scars recently, they're very, very thin. They're very, very discreet, especially in white people. You may not even see it at all. It might be very faint. So you're not always going to see the release scar. Okay, can anyone describe what they see in the left picture and then tell me what the name of it is?
Someone's written hammer finger, someone's written swans, swan neck, buttonhole, swan neck, lots of different answers.
Okay, so the patient on the left with the purple background has a swan neck deformity. So the way you know it's a swan neck is you have flexion at the distal phalangeal joint and extension at the proximal phalangeal joint. Compare that to the right, which is a boutonniere. You've got extension at the distal joint and a little bit of flexion at the proximal joint, although classically you get a little bit more than that. Okay, so left is swan neck, right is boutonniere. Okay, can anyone tell me about the patient on the left? Just tell me the diagnosis.
Someone's written trigger with lots of exclamation.
Perfect, love the enthusiasm. And then the patient on the right.
Someone's written OA.
Okay, and what's making you think OA, whoever that is? What particular signs are leading you toward that?
Base of thumb.
I'm going to need more than just base of thumb. Base of thumb what?
Someone's written square thumb.
Okay, so what we're looking at in this one is a Z thumb. So you can see, I don't know if you can see my cursor. Can you see my cursor?
Yeah, we can. Someone's also asked if they're jaundiced. I think that it's a cadaver, just saying.
I also think it's a cadaver, but it's not my picture. I think it might just be the exposure on the picture rather than yellowing. But yeah, you might be right. It might be cadaver as well.
Someone's
yeah.
written hitchhiker's thumb and Z thumb.
Hitchhiker's thumb. I've never heard of hitchhiker's thumb, but I'll take your word for it. Yeah, Z thumb. And then, okay, can someone tell me the name of the lumps on the left in the black picture?
We've got Heberden's nodes.
Yep, those are in fact Heberden's nodes. Can someone tell me about the blue picture, the bottom one? The bottom one is admittedly a little less clear. It was quite hard to find pictures for this one.
Someone's written Bouchard's nodes.
Yeah, so Heberden's are your distal joint, Bouchard's are your proximal joint. They're both fairly good signs of RA. It's very rare that you'll find one without the other, which is why it's very hard to just find a picture of a Bouchard node. And then can someone tell me what's happening to the lady in the blue sweater at the top?
Someone, rheumatoid nodule, epiclear nodes inflamed, rheumatoid nodules, gout.
So these are rheumatoid nodules. Gouty tophi tend to be a lot more smaller and kind of have a yellow tinge to them. This is just a reminder to make sure when you are doing your exam of the hands, you need to get the patient to unroll their sleeves up to their upper arm above the elbow. You can get a lot of information by looking at both elbows, especially gouty tophi and rheumatoid nodules. Rheumatoid nodules tend to present most classically in the hands, wrist, feet, ankles, and elbows. So make sure you keep an eye out for those. And that concludes the hand exam. So I'm just going to go through examinations in general. So for joint exams, it's fairly rare that you will need bloods. And remember, anytime you mention bloods, you need to ask for the specific ones that you want. You can't just ask for blood tests. So examples I've given here. So if you can ask for a full blood count if you are considering infection, so you would be looking for a white cell count. U's and E's tend not to be super applicable here. If you are suspecting gout, then you may ask for a U and E for a urea, but it's unlikely. CRP is a good marker for infection. It's not as good of a marker of autoimmune inflammation as ESR is. So make sure if you are suspecting rheumatoid or any of the autoimmune joint conditions, you ask for an ESR. Autoimmune markers, so you've got your anti-Rho, anti-LAR, rheumatoid factor, etc. Make sure you sit and just learn that list of autoimmune markers. They're really easy, quick marks to get in an SBA, and really nice ones to be able to demonstrate in an OSCE because it shows you know what you're doing. Now, I don't always get a bone screen for, I wouldn't always get a bone screen for an OSCE patient. If they have a fragility fracture, so for example, a wrist fracture from a fall or a fractured neck of femur, or if they are high risk for osteoporosis or osteopenia, so let's say they have hyperparathyroidism or they are on steroids, or if from your exam generally you think they may have hyperparathyroidism, then I would consider getting a bone profile. So a bone profile will include a calcium, a vitamin D, a phosphate, a parathyroid screen, and sometimes a magnesium, depends on the trust. Sometimes they put them in, sometimes they don't. And in that case, if you are going to get a bone profile, then you do need a U&E because calcium, phosphate, magnesium, and potassium all kind of have a lot of crossover of compensating for each other and all sorts, so make sure you get a U&E. I wouldn't even standardly mention it unless I have high suspicion in an OSCE, but it's up to you. X-rays will be your port of call as far as imaging. I would, no matter what your patient is presented with in the OSCE, I would get an X-ray. In the real life, I wouldn't get an X-ray for every single patient because although it gives you information, remember when you're asking for a test, it's because you want it to inform your clinical reasoning. So when you're getting an X-ray, you are looking for it's not going to give you soft tissue, it's going to give you bone. So you're looking for fractures, any bony deformity, any dislocations of joints or subluxations. And then in the case of osteoarthritis, you are looking for your classic loss signs. So loss of joint space, osteophytes, sclerosis, and the subchondral cysts. That's right, yeah. That's all your X-ray is going to give you. MRI, it's rare that I think you'll be presented with a condition in an OSCE that would need one. Remember, MRI is really good for soft tissue. So it's going to tell you about muscles, it's going to tell you about ligaments, tendons, cartilage, that kind of thing. So I would suggest it potentially if I thought a patient had a rotator cuff issue, or if I thought they had a rupture of any of the ligaments of the knee. Otherwise, I probably wouldn't even mention it. And then CT, you will not be asked for a CT in an OSCE. I think that would be quite ridiculous. CT in orthopedics tends to be used only really for massive polytrauma cases, so that the surgeons can visualize exactly what the fracture looks like. Or if you have a patient whose fracture is not healing as you would expect, you would do a CT to check for malunion. However, at your stage for finals, you don't need to know that. You don't need a CT. X-ray will be your first port of call. MRI if you think there's a soft tissue issue. Right.
Someone's asked, would you want U&Es to check the EGFR if analgesia was required?
That's a fairly good point. I guess it depends on the station. If the station says you are in A&E and this patient comes to you after coming off their bike, they're probably going to need surgery. and as admission bloods, you would be using these anyway. If you have a patient, if the brief says you are a GP and a patient has come in with a 2-month history of shoulder pain, I probably wouldn't, not as standard, unless I have reason to suspect they may have some degree of renal issues. But you can mention it. If it's an acute issue, then maybe mention it, because the patient may need surgery and will need a UNE anyway. In the primary care setting, if it's a long-term issue, probably not. Any other questions?
Okay, looks like now the questions.
Okay, this next section is kind of up to you guys. So the GALS exam is an exam used by rheumatologists to assess the overall function of the person's joints as far as their ADLs. Now, it was invented at UCL, so UCL tend to love it and have examined it maybe a handful of times over the last 10 years. But outside of London, I don't think I've ever heard it used, and I've never used a joint GALS exam in the entire foundation training. Would you like me to go through it? Because I don't know where you guys are studying, if it's on your curriculum, what have you.
Someone's gone, go for it. We've got a couple of yes pleases. More yes pleases.
Okay. Okay. So most of GALS is the inspection. I'd say at least half of the marks is for the inspection, half of the signs you'll list is just looking at the patient. So GALS stands for gait, arms, legs, and spine. While this is a useful acronym to use, I would not examine the patient in this order, because it'll have the patient standing up, sitting down, lying down. It comes off messy. I personally do it gait, spine, arms, legs, but you can work out what's going to be best for you. So first is inspection. There is a lot to go through. So take your time with it. Remember, front, side, back, and you're looking from head to toe. So ideally, you would have your patient undressed to underwear. Before you start, so the screening questions that you ask anyone in a GALS exam, remember GALS is for activities of daily life. So that is, that's your reference point. So you're asking them, do you have any pain or stiffness in any of your joints? Do you have any difficulty dressing? And do you have any difficulty going up and downstairs? Remember to ask both. For inspection, right, I'm going to take a sip of water because this is going to be a lot of talking. From the front, you are looking at the shoulder bulk. Remember, you're always looking at both sides for a change in the symmetry. You are looking at the quad bulk. You're looking at the knee alignment. Is it normal? Is it varus? Is it valgus? And you are looking at the foot arch. If you are assessing someone's foot arch, you need to get down on your, either into a deep squat or on your knees, and look at that foot arch. You can't do it from standing. You can't even do it from kneeling, I don't think. Make sure you know what a cavus foot looks like and what a planus foot looks like, because sometimes it can be quite subtle. From the side, you are looking at the curvature of the spine. So you're looking for the natural arc of kyphosis and lordosis that should be present in the spine. You're also looking at the elbow carrying angle. So the patient is still standing at this point. You get them to rest their arms by their side and just look at the rough angle at the elbow. In men, it tends to be 5 to 10 degrees. In women, it tends to be 10 to 20 degrees, usually around 15. Then from the back, once again, you're looking at the posterior shoulder bulk. You're looking at the alignment of the spine. So you're looking for any degrees of scoliosis. You are looking at the resting iliac crest level as a fairly good representation of the alignment of the pelvis. You're looking at the hamstring bulk. You're looking at the popliteal swelling. You're looking at the bulk of the calves, and then any Achilles swelling. And that is inspection. It is a lot to go through, but it is at least half of the marks just there. Feel free, if you want at this point, just to take a picture of the diagram I did. I'll give you a couple seconds to do that. Okay. Gait. As we've said over and over again, you are looking at the 5 S's of gait: smoothness, swing, symmetry, stride, and speed of turn. Once again, the gaits you should be able to describe are antalgic, ataxic, hemiplegic, and Parkinsonian. Arms. So this is best done with the patient sat down with their hands in front of them. You can always position a pillow under the arms, because I find it a little bit easier to examine the hands like that. So I always start from proximal to distal. So palpate all the way around the shoulder for tenderness, as I showed you earlier. You're going to do the arms behind head test, because it's a fairly good functional test. You get them to supinate and pronate their forearms, noting for any tenderness or stiffness. Then you inspect the hands. Remember, when you're inspecting the hands, you're looking at the back and the fronts of the hands. You comment on the thenar bulk. Remember, thenar bulk is going to be a sign for if there's any carpal tunnel syndrome or any medial nerve disturbance. Squeeze across the MCP joints. You're going to test grip strength. So put one finger out on each side, get your patient to squeeze both fingers and compare one side to the other. Is it symmetrical? Is it weak? And then dexterity. You get the patient to make the OK sign with their finger and thumb and touch the thumb to each finger one by one and then back as quick as the patient is able to. I tend to do these one by one because I think it's hard to watch both hands do it at the same time, but whatever works best for you. Legs. So get the patient to lie back on the bed, actively flex the hip to 90 degrees, actively flex the knee to 90 degrees. You're going to do your knee effusion test of choice, squeeze across the MTP joints, MTP, yeah, and then examine the arch of the foot. I personally find it easier to do the arch of the foot when the patient is standing, because I think it's easier to see how arched the foot is from the floor. But you can do this lying with them lying back as well. And then spine. Spine's probably the weirdest one out of the four. So you get them to tilt their head side to side as far as they can get it. I find the easiest way to get them to do this is try and ask them to try and touch their ear to their shoulder. You get them to move their jaw side to side, which I think always looks really stupid, but hey ho. Then get them to stand up and bend forward and touch their toes as far as they can. While they're down, you can do kind of a shortened version of a Schober test. So all you're going to do is place 2 fingers on 2 adjacent lumbar processes and then ask the patient to come back up. In a normal patient with no stiffness of the lumbar section of the spine, the fingers should get slightly closer together. In someone with lumbar stiffness, they'll stay completely straight because that section of the lumbar spine isn't able to flex back. That is your GALS exam. So I would always do, my way of doing it as I do the full inspection with them stood up. So I've got them stood in the middle of the room, do the front, do the side, do the back. I would then do G. I would get them to do gait. So walk up to the end of the room and then I could walk them back. While they're stood, I would then do the spinal test because you're going to need them to bend forward and touch their toes. So get them to do the head stuff, get them to bend forward, touch their toes, do the lumbar thing, and then get them to bend back up. From there, get them to sit on the side of the bed, and you can go through the entire arm exam. From there, get them to lie back, you can do the entire legs exam. If you do it in order, I find it just a little bit messy because you do the gait, and then they're sat down, and then they're lying back, and then you're getting them to get back up. It's not so smooth. But if you get stuck in the exam, just stick to GALS, do it in order. If that's going to help you remember, then do it that way. The smoother you can get it, the less time you're going to waste faffing about getting the patient up and down, around. So yeah, that might be useful for you. Do we have any questions about the GALS exam? Do we have any questions that I haven't resolved about any of the other exams or about OSCEs in general? before we move on to the quiz quickly?
There are a couple of questions earlier. I just need to scroll up.
Go for it.
Dun, dun, dun. Oh no, I think you've covered them. Let me see if there's anything new. Would you ever routinely test sensation or neurovascular in an OSCE? Or just say you would?
Just say you would. Yeah, I would just say, because I don't think you'll have time. If you're doing a very thorough exam and doing all the special tests, I doubt you'll have time. When I did OSCEs, all of my joint stations were 5 minutes, and I don't think you'll be able to execute a full joint exam with specials and a neurovascular exam in that time. However, if you say, I'm going to do a neurovascular exam of the limb, and they hand you a tendon hammer and a little red point, go for it, do it. Clearly that's part of the mark scheme.
Yeah, I'd agree. I mean, a neurovascular exam is a whole other exam. If they tell you to do a joint exam, just do the joint exam.
Yeah, always answer the question.
Someone's written, do we do joint exam in trauma or unconscious patients?
In the real world?
In the, I guess in the real world.
I
guess they mean in trauma.
Oh, like in A&E?
Yeah.
Yes. If you think a patient, well, if a patient has had a massive polytrauma, let's say they've been in a road traffic accident and they've been brought by ambulance, it's likely that that ambulance would have called ahead saying, I have a blue light polytrauma patient, please prepare everything. And you'll likely do a trauma CT. So trauma CT is a head to toe full body CT scan. So it is unlikely that if you have a massive trauma patient, you'll have to examine a joint, because it just takes too much time. You need to get them in that scanner so you can find exactly where the trauma points are. And so the orthopods can start prepping emergency theatre. Unconscious patients, it depends why they're unconscious. Like if it's the same case that it's a polytrauma patient, you would put them through a CT scanner. If they're unconscious because they've gone into some kind of coma from something medical, doing a joint exam wouldn't be a priority until they're awake again.
Yeah. There's actually primary surveys and secondary surveys that you can read about in trauma, which are really good. There's a lot more questions. Someone's asked the leg length test. Some say you need to measure from the umbilicus, not the sternum. Is there an issue with using the umbilicus? Depends on the size of the patient's tummy.
Yeah, that's very true. I've always done it from xiphisternum. Either way, the point is you're not demonstrating that the patient's you're not making a decision based on the patient's leg length. You're making a decision based on whether the leg length on one side is shorter than the other. So whatever your reference point is, just use the same one on both sides.
Someone's asked, are you likely to do a session on neurovascular status of a limb? So we're doing lots of different sessions that you can find on our Eventbrite page. We're not specifically doing neurovascular status of a limb, but we're doing vascular exams. Then someone asked, is there a difference between joint exam in adults and children?
No, not really. Kids tend to be less cooperative, and the pathologies will just be a lot different. Remember, in kids, something like septic arthritis is a much more likely case than in an adult, and also something like osteoarthritis or rheumatoid or any of the polyarthropathies are much less likely. For finals, you won't be given a PEDS joint exam. I think that would be incredibly harsh. You'll be given a PEDS, like specific PEDS exam.
I think that's it for the questions.
Wonderful. Right, I got a little quiz if you guys want to stick around. It's literally 3 questions. Right, you have a patient on the left demonstrating a Trendelenburg test. Which side is affected?
Oh, we've got lefts and rights here.
Interesting. Right. Not right. Okay. So this was a slightly trick question in that the sign that's being elicited in this patient is not a positive Trendelenburg, for the reason that a positive Trendelenburg sign is when the leg that you're lifting off the floor tilts down. On this side, he's leaning in towards the leg that's planted, and therefore it's not Trendelenburg positive. You would need to do both sides. He may have a slight degree of right-sided weakness if he's having to tilt towards the side. However, this patient is not Trendelenburg positive based on the finding that you found here. A positive finding is for the opposite, for the side of the pelvis away from the affected side to tilt down when it's lifted off the floor. So that was a trick question. Right, question 2. In the picture at the top with the gentleman in the black tank top, what rotator cuff muscle is being tested?
Supraspinatus, people have written.
Perfect. And in the picture at the bottom, what ligament of the knee is being tested?
ACL, MCL, medial ACL.
So this looks like he's doing a Lachman's, but he's actually doing a collateral stress test. So MCL is correct here. If you could see the full leg, unfortunately his elbow is kind of hiding it, but if the bottom half was being rotated out, then it would be more of a Lachman's. But if you look the direction he's pressing towards the medial collateral ligament, so that's the one that's being stressed and tested in this case. Well done, guys. It's been a whole marathon. I hope that's been useful for you. A few different resources that I found really useful as a med student. So OSCE Stop and OSCE Aid are really, really good for going through the exams in a stepwise way. Geeky Medics is also really useful because it'll tell you pathology at each stage and what the signs mean. I personally haven't used Almost a Doctor or Oxford Medical Education, but I know a lot of people who have and found them really useful. And then as far as the tests, the physios get taught how to do the tests, the special tests, far better than we do. So I tend to use their resources more than the medical resources. So the ones I've found really useful are FIFA TV and Physio Tutors. There's really good videos that go through everything in a very stepwise fashion, and it's taught really well. And finally, if you don't have this book, we are not sponsored by this book, but it's a book that I found very useful. This is not a merch drop, but OSCE Cases with Mark Schemes is a really, really good book. It's really comprehensive. It gives you mark schemes. It gives you history stations. It gives you scenarios. It's really useful. So make sure you get it. Please don't get it from Amazon because Jeff Bezos does not need any more money. It is available at Waterstones and any other good textbook provider. There may also be copies in your university library. Please, please, please do the feedback forms. I would appreciate it so much. We have all put a lot of effort into making these all happen. And if you want to keep up with all of the events we have coming up in the next couple of weeks, you can follow us on socials. So we are on Facebook and Instagram at medicine.the.essentials, or we are on Twitter at medicinete. If you have any queries or anything else you want to add, you can send us an email on medicine.the.essentials at gmail.com. I really hope that's been useful. Do you guys have any final questions or anything you want to add?
Lots of really, really sweet thank you messages going through. You might want to have a look at the chat.
Oh, cute.
Yeah. See if there's any other questions. Oh, someone's first time attending, saying it was super informative. Thank you so much. As soon as you guys do the feedback later on tonight, I will send out all the certificates. Please do the feedback. Again, it's all free. We do it because we want to teach and we think that we should give you lots of teaching. All we ask for is a feedback link.
Oh, someone's saying
make sure the link is working.
now.
It should be working. It's working for me. Is it working? I've got some feedback forms done. Is it working for everyone else?
I'll click from my side. Yeah, it's working for me.
Okay, good. Look, it's working.
Right. Have a wonderful evening, guys. Take a break because that was intense. You guys are going to do absolutely fine.
All right, guys, last chance to make sure you click on that link before I end the chat. Thank you all for attending. Thank you, Arpan, for that. I actually learned a lot. It's been a long time since I've done the exam. Which email do you contact if you have a query? Let me type it in for you. It's medicine.the.essentials@gmail.com. Maybe one day I will register for a shorter email address.
Yeah, it might be a good idea.
Yeah. I probably will. I get asked this a lot. Okay, great, guys. That's it.
Right, I'm going to bounce.
Right.
Bye.
Thank you. Thanks, everyone. Bye.